clinical lead amputee physiotherapist here at the Mobility Centre. I've been working here for 2.5 years, and I work with amputees of all ages, from children through to elderly, from all levels, from quadruple down to unilateral amputees at transfemoral, transtibial level.
So Hayley, what's the prevalence of lower back pain in your patient group at the moment?
So there is a high prevalence of lower back pain in our patients. It tends to be in the patients that either have a long history of lower back pain and they're coming in as a new patient, and it causes a bit of an exacerbation of their pain. So you can have a patient that's been sat in a wheelchair for a long period of time, which leads them to get quite stiff and quite sore. I would say the majority of patients, if they're going to get lower back pain, they tend to get it a little bit later on. So I would say after they've been established for a year or two, we get a build-up of lower back pain at that kind of level. But we do get patients that initially have back pain after surgery.
Do you think there's an association of lower back pain in a particular group, such as like males or females, or above knee or below knee amputees?
I definitely find that the younger sort of children, teenagers and early 20s don't really tend to get any back pain. I would tend to find that the bilateral amputees definitely do. They do tend to be thrust forward on when they're mobilising onto their toes, so get a lot of extension in their spine, so they tend to have a lot of problems. And the transfemoral amputees definitely have a higher prevalence of lower back pain compared to the transtibials.
And do you think lower back pain is as problematic as other associated disorders like phantom limb pain with amputees?
As problematic?
Yeah.
I would say that phantom limb pain is probably more problematic than the lower back pain. A lot of patients have had some form of lower back pain and tend to manage okay with it. I think phantom limb pain is very debilitating just because of the intensity, because it is neurogenic. It tends to have more of an impact on their life and their sleep, whereas lower back pain can be managed quite nicely with painkillers and exercises. So I think the patient feels a bit more in control of their back pain rather than neurogenic pain.
So how is a typical back pain patient managed in this amputee setting?
Okay, well, from our point of view, we do a lot of preemptive management. So with all our amputees, we tend to do a core stability program of some description. So we want to prevent the main things that I find that cause problems. So one of those is making sure the hip flexors are stretched, because obviously the origin and insertion, that can have quite a force on the lumbar spine. We do gym ball exercises as soon as the patient can do some form of gym ball exercise. We can do, with more of the established patients, I tend to utilise TENS, and I can do MOBs, PAVMs, PIVMs, you name it, anything that's used in outpatients I have used. But I tend to do that more with the established patients that have had it for a longer period of time. In the early days, it's all exercise based, so lots of active exercises. We can assist them with stretches. We have acupuncture as well, we do provide that, acupuncture TENS. I've got to think of all the different things. We do some quadratus lumborum. We find that quadratus lumborum tends to get quite overactive, so we can do some specific soft tissue work as well to help release that as well. But obviously we want to make it a very sort of patient management, give them the tool set so that they can manage it themselves. And because in the future you might find the patient is going to have exacerbations, we need to give them a toolkit so that they can manage this problem into the future. And heat. Lots of heat, yes.
Do you think the advancement of prosthetics over the years has had an influence on lower back pain?
Yes, I would say. I think the problem being in the NHS is that we don't necessarily see as much of the high-end sort of microprocessing and all these fancy bits of kit that reduce the energy expenditure and improve the efficiency of gains. So I think from an NHS point of view, I can see the theory behind it, and I'll expect it will do, but we don't see it as much here because we don't get prescribed the higher componentry. But I find that patients that have, if they are not having to lug around a fixed knee, then they're not putting as much strain on. They're not putting as much strain on their back. So I think it's very difficult in the NHS setting to say specifically whether it has or hasn't. But I anticipate it will. And in the future, we will be having more microprocessor knees and components that will improve energy efficiency. So I think for the future, that will definitely be an area to investigate.
And do you think that amputee patients with lower back pain present with more yellow flags?
I think as a group, generally, there are more yellow flags before the patient even had an amputation. There is a certain patient group, subjectively, that have problems that can lead to them having amputation. So I'm not sure that the amputation causes the yellow flags, but I do feel there is a high prevalence of yellow flags with lower back pain patients and amputee patients as a general. I wouldn't say specifically just for lower back pain.
Okay. And how would you manage things like anxiety or depression in this patient group?
Yes. Well, I think for us here, I think with our setting, we have very much, we have a nice group setting. So we have lots of people in a very similar situation, so they can have, if the patient's willing, can have a bit of a group session discussing it. We also have, discussing the problem, and we also have CBT. So we have CBT that we can refer to. Is this for the psychological side of things?
Yeah.
We can refer back through the GP for psychological management if we think there's something a little bit more severe going on. We have been involved with crisis teams, GPs, psychologists, and there's more, I can't think of them. Just repeat the question one more time.
How do you manage the sort of anxiety and depression, so the yellow flags that come with the patient group?
Yes, so we've got CBT. I'm thinking, what am I missing? Yeah, group settings, and we can do individual one-on-ones. We do a lot of sort of managing challenging patient things, like paraphrasing and all those different techniques in our interviews as well to help them through. Goal setting is a key thing, making goals that are specific to the patient and that help them to do tasks. So visual acceptance and yellow flags associated with that will get the patient to sit out in the waiting room without the blanket on their leg.
Yeah.
So bits and pieces like that. Does that answer your question?
Yeah, that does.
Are you sure? I'm going to think of something else straight away, but I can't remember right now.
Thank you very much.
That's all right.